She is the director and senior consultant at Akash IVF Kanpur, and she is practicing for last 35 years with a huge experience in laparoscopy, colposcopy, and an ART specialist. She has gotten academic achievements in the form of she has been speaker, invited faculty in more than 600 national and global conferences along and had chaired more than 500 sessions. She has organized national conferences at Kanpur in 2023-24, and Madam would be speaking about the approach towards pelvic masses. Ma'am, the stage is all yours.
First of all, my sincere thanks to this august audience, and thank you for the Jaipur team, Dr. Veena Acharya Madam and whole team working day and night for organizing such a wonderful conference. My regards to chairperson and all the seniors. Dr. Veena Acharya Madam then told me to speak about the step-wise approach to pelvic masses. I was very happy because this is a burning topic. Usually we private practitioners in our practice do get so many such cases in which we have to see and differentiate which type of pelvic mass is this, especially when the patient comes to our OPD and the practicing person is a newborn. With the experience, we know how to differentiate the different pelvic masses. The pelvic masses, if a patient comes to you, you have to differentiate depending on the cause, depending on the time of presentation. Patient may present in infancy, may present in prepubertal age, may present in adolescent, reproductive age, perimenopausal, or the postmenopausal age. So there are different causes in different age group. Like in infancy, the functional cyst may be in any of the age. Germ cell tumor, they are in infancy and the prepubertal age. Adolescents may have few complications of sequelae of PID, benign cystic teratoma, other germ cell tumor. There may be other epithelial ovarian tumors even. In reproductive age, of course, we have to rule out pregnancy. There may be ectopic pregnancy, maybe uterine fibroid, maybe epithelial ovarian tumors, maybe mature cystic teratoma, or the tubulo-ovarian masses, maybe septic embolism. Perimenopausal, of course, fibroid, epithelial ovarian tumor, and the functional cyst is always there. Postmenopausal, there may be ovarian tumor, maybe malignant. You have to keep all these things in your mind and have to differentiate always. Maybe other than the uterine and the broad ligament thing, you must keep the other organ disease like bowel involvement, maybe bowel malignant tumor, or maybe inflammatory, or maybe metastasis that you have to look into. So you can divide these all things into the uterine origin, into the adnexal origin, intestine, and the other origin. Uterine origin, of course, I have discussed already: fibroid, adenomyosis, hematoculpose, pyometra. Adnexa, that may include ectopic pregnancy, may include many different type of ovarian tumor masses, chocolate cyst, tubo-ovarian mass, and pelvic abscesses. And intestine and other may have appendicular lump, impaction of worm. This is a very important condition. Many of us, even I have seen many cases of infection of worms in the abdomen and may present like a pain in abdominal lump even, iliopsoas abscess and pelvic kidney, very important condition. Many times there was a patient of even mine was while doing ultrasound, the kidney was missing at the original base, and we found it in the ultrasound this was a pelvic kidney. So pelvic kidney may also present as a pelvic mass that should be kept always in the differential diagnosis. So there may be pregnancy related conditions, maybe normal uterine pregnancy, that is the first condition that you have to keep in your mind. You have to keep in mind all ruptured extrauterine pregnancy may present as a abdominal tubal pregnancy, may present molar pregnancy. Uterine origin things are uterine fibroid, advanced uterine carcinoma or sarcoma may be there, maybe hematometra, and even pyometra. Of course, along with that, there may be temperature and other features. I'll come on that those very points also. Tumor origin may be hydro or pyosappings, may be ovarian abscess, may be advanced cancer of the tube even. Ovarian origin, that may be ovarian torsion. If the cyst is big, then it get torsion on its own pedicle. Benign cyst, endometrioma, benign tumor, then white fibroma, cyst adenoma, and the borderline tumors. Malignant tumors, of course, we all have to keep in our mind. Differential diagnosis, of course, with the same conditions. Appendicular abscess should always be kept in mind. Obstructed hernia, intussusception, colorectal carcinoma, subacute intestinal obstruction. These are the causes other than the obstetric or gynecological causes. Diverticular abscess, large bowel tumor, mesenteric tumors, abdominal aortic aneurysm, renal tumor, pelvic kidney, I have already narrated, bladder, carcinoma, and even urinary retention. Urinary retention, I'll come on the point, this is very important condition. Many times it happened, especially when dealing person is RMBs or paramedics. They usually don't see the very full bladder, and they many times without doing ultrasound confuse that this is some abdominal mass. What is the way? You just catheterize and it just disappears. Neurological condition, neuroblastoma is there. Amongst hematological, there is Hodgkin's and non-Hodgkin's lymphoma. Pelvic spleen even, that is a rare condition, but that may be there. You have to differentiate. Pregnancy and full bladder are physiological causes. In case of full bladder, as I have already narrated, that if you do catheterization, this disappears. So that is a important point that you have to keep in your mind. So pregnancy, that is a intra-uterine pregnancy. Of course, you have to see the other points. That is the cessation of menstruation and gestational sac while doing ultrasound is always there. Uterine fibroid, if we narrate in detail, we have different type of uterine fibroid, subserosal, intramural, submucous myoma. These all are there. This is a picture of different type of leiomyomas that you have to keep in your mind, that you have to differentiate with all these. Benign ovarian tumor is one of the most important condition from which you have to differentiate while doing stepwise examination for pelvic masses. So benign tumors, these are predominantly occur in late childbearing ages, and while doing abdominal examination, usually you find the bulging of lower abdomen, mass may be unilateral or bilateral, ascites may be present along with this. On pelvic examination, there is a swelling, movement of the mass per abdomen fails to move the cervix because this is a separate. So with your experience, you can just know whether this is attached to uterus or this is a separate mass. There is the absence of pulsation of the uterine vessels through the fornix. This is a very important point. Now coming to the malignant ovarian tumor, they will also be there in our differential diagnosis. In this, of course, along with features of abdominal masses, ovarian cystic masses, there are other features of the malignancy also. Patient may be catechic, may be paler, may be having jaundice, left supraclavicular lymph node may be even present, enlargement and edema of the leg and vulva may be there. So abdominal examination, usually the mass is bilateral, may be fixed, solid, irregular, and even by the secondaries of the liver, there may be enlarged, formed liver. On pelvic examination, uterus is separated from the mass, or many cases may be mixed with this. Nodule may be felt through posterior fornix. Now, other condition is very important, that is adenomyosis. Adenomyosis is a condition where there is ingrowth of the endometrium into the glandular and the stromal component directly into the myometrium, associated with paler female above 40 years, where it is more common. So here you have to see that patient is presenting with the features of either menorrhagia, dysmenorrhea. These features are mostly associated with it. On abdominal examination, uterus is usually enlarged. 14 to 16 weeks pregnant live uterus may be felt by the examination. Pelvic examination, you can see a uniform and large, well-defined margins of the uterus. Internal examination, usually you can see swelling. Endometriosis is another condition you have to differentiate. Now, because we are seeing that because the incidence of infertility is increasing, and in every conference we are talking about the endometriosis. It is the most common condition which occur in especially white nulliparous women between the ages of 35 to 45 years. Present with a cystic pelvic pain or the pressure, dyspareunia, dysmenorrhea, dyschezia and infertility. Most common may occur on the ovaries and occasionally can form the large cyst, even chocolate cyst. We are seeing in many of our cases that chocolate cysts are present. So laparoscopy is the gold standard for its diagnosis and the treatment. Other very important condition by which we have to differentiate is tubo-ovarian abscess. Usually, because if there are features of sepsis, salpingitis, then we see that there are adnexal tenderness and cornices are full. In this, tubo-ovarian abscess are present and we have to differentiate. Usually, diagnosis by ultrasound or the laparoscopy may be confirmed. So, few important points while we are doing stepwise differentiation of different pelvic masses and diagnosing. History is very important, examination and the investigation. Coming on the history systemic and symptomatic assessment especially are very important. As a general examination, we have to ask from the patient whether she has a history of pain. Since long this lump was present in the abdomen, she is having a fever, bloating frequency, history of weight loss or loss of appetite. Every point should be seen in the history. Should see about the menstrual history, that is very important. Sometimes there is a history of secondary amenorrhea which suggests there may be history of pregnancy, that because of amenorrhea you can judge that pregnancy may be there. There may be ectopic pregnancy, pelvic pain in second half of menstrual cycle could be due to hemorrhagic corpus luteum cyst, maybe menorrhagia. Because in this we have to rule out submucous fibroid, dysmenorrhea, endometriosis, fibroid and PID. So obstetric history as well as past medical and surgical history, all is very important. Contraceptive history, this is very important. Why you have to ask about the contraceptive history? OCs, they reduce the likelihood of the functional cyst, but they are more likely to have PID. Ectopic pregnancy are more common among the IUCDs, intrauterine contraceptive devices. Other character of the pain is very important. Sudden onset of the severe pain that suggests ovarian torsion. There may be, you have to always keep in your mind that this may be a case of ovarian torsion. Maybe hemorrhage into the cyst, maybe a rupture of the cyst or abscess or ectopic pregnancy, you have to rule out. Cyclical menstrual pain associated with menorrhagia and passing clot suggests fibroid. Cyclical menstrual pain associated with back pain or dyspareunia suggests endometriosis. These are few important points. In the same way, the progressively worsening pain associated with constitutional symptoms may suggest some typical type of ovarian tumor, ovarian cancer. Patient present only with the vague gastrointestinal complaints when there are secondaries. So examination is very important in these very cases. General physical examination as is must, as we are always teaching from UG days that every patient should be done very good physical examination. Head to toe examination is very good. Cachexia, carcinoma, pallor, maybe because of the excess blood loss in ectopic pregnancy, rise in temperature is very important. May show abscess, tubo-ovarian abscess, abdomen should be checked for the ascites or ovarian tumor. Characteristic of all the masses include size, shape, mobility, consistency, everything should be seen. Cervical discharge with mucus, PID, we have to rule out adnexal masses or tenderness should be seen. Cervical motion should always be done. You do PV and try to move the cervix and see its movement. See the uterine enlargement. Rectovaginal area assessment is very important. Posterior uterine surface, especially uterosacral ligament and the rectum should be seen. You should see about the lymph node, supracervical and the groin nodes are very important. Abdominal examination This is very important. See about the some previous history. Ask many times the patient in younger age or adolescent doesn't give the history of previous surgery. You have to inquire about it. Features of the ascites, shifting dullness, fluid thrill, palpation of the mass is present is very important. Speculum examination, per speculum examination, as our teachers and we are always teaching to our students that we should always do the per speculum examination. Very important. Inspect the vulva, vagina and cervix in all these cases if the patient is married. Bimanual examination, and in the same way the rectovaginal examination is very important. Coming on the investigation, urine pregnancy test, of course, to rule out the pregnancy, beta HCG, full blood count, urea and electrolyte, blood grouping and the cross match, ultrasound scan of the abdomen as well as the vagina. CA 125 is very important investigation to rule out the cancer. This may also be elevated in endometriosis, adenomyosis, fibroid and PID. So ultrasound, CT scan and MRI, these are again very important investigation which we should do to see whether the masses, size of the masses, whether they are solid or cystic, and in case of tonsil, emergency laparoscopy may be advised. Asymptomatic or minimally symptomatic fibroid may be followed. Symptomatic fibroid may require hormonal suppression. There are now many other modern modalities by which we can treat. Tubo-ovarian abscess and the hydrosalpinx in cases of PID are best managed through the hospitalization, IV antibiotic, and sometimes require drainage of the pus and even laparoscopy. Ruptured ectopic, if it is there, then we have to treat. The management that depends on the cause. What you see in that very patient. Endometriosis in the same way. I have only a very small presentation of 4 cases. First case was 45 years old, P2L2, with the complaint of heaviness in abdomen, irregular heavy menses, dysmenorrhea since last 2 to 3 months, and per abdomen it was soft, non-tender. Cervix, vagina healthy. While per vaginal examination it showed to be soft to cystic mass 4 into 5 centimeter in right and posterior fornix, and this was separate from the uterus. On per rectal examination, there was a boginess felt anteriorly. So this came to be on ultrasound solid hypoechoic well circumscribed right adnexal mass of size 3.6 into 4.6 centimeter. So what is your diagnosis? The broad ligament fibroid came to be in this very particular case. And the impression ultimately was mucinous stellinoma of the ovary of the benign etiology. And the same was the impression that came in the CT scan, left ovarian stellinoma of the benign etiology. This is a diagrammatic representation. Intraoperative finding. This is a operation, and that proved the diagnosis. Case 3 was a 30 years old female, 5 years, she came with a history of infertility, 5 years, married life 5 years. Progressive cyclical dysmenorrhea since last 1 month. On per abdomen examination, there was no burdening, rigidity, distension and tenderness. There was a bogginess in the left and the posterior cervix fornix measuring 5 into 5 centimeter. Left adnexal mass of 6 into 5 centimeter with thin septation with no vascularity was there. So on ultrasound there was a thick walled homogeneous ground glass appearance. So I think by this statement only the diagnosis is very clear to all of us. What is the diagnosis? Diagnosis came to be endometriosis, chocolate cyst. Left tubo-ovarian chocolate cyst, C with a dense adhesions to the bowel. The last case and the case 4 is 28 year, P2L2 with the property 380A was kept in C2, and there was dull lower abdominal pain with white foul smelling PV discharge. So on examination there was tenderness, left fornix was full and came to be left tubo-ovarian abscess. Thank you very much. these are few cases and how to differentiate.
Thank you, ma'am. Only one word.